Bismillah ar-Rahman ar-Rahim. Our lecture today will be about congenital hypothyroidism. The objective of this lecture is what is the definition, what are the causes of congenital hypothyroidism, what are the clinical features, how we can reach the diagnosis, and what is the treatment of this condition, and what about the prognosis. Hypothyroidism is resulting from deficient production of thyroid hormone or a defect in thyroid hormone receptor activity. The disorders may be either congenital or acquired. We will come across the congenital hypothyroidism and the other types of hypothyroidism. You will take it in medicine. As congenital hypothyroidism is unique for the pediatric department, congenital hypothyroidism, most cases of congenital hypothyroidism can result from thyroid dysgenesis. Some cases may be either familial, usually caused by one of the inborn error of thyroid hormone synthesis, and may be associated with goiter and sometimes without goiter. Regarding the epidemiology, the prevalence of congenital hypothyroidism based on the neonatal screening is about 1 to 4,000 infants, with male to female ratio equal to 1 to 2. All the thyroid problems are more common in females than in males. The etiology, thyroid dysgenesis, which means either aplasia, hypoplasia, or an ectopic gland, is the most common cause of congenital hypothyroidism, accounting for 85% of the cases. 10% are caused by inborn error of thyroxine synthesis, and 5% are the result of transplacental maternal thyrotrophin receptor blocking antibodies. About the clinical manifestations, most infants with congenital hypothyroidism are asymptomatic at birth, even if there is complete agenesis of thyroid gland. This is due to the transplacental passage of moderate amount of maternal T4, which provide fetal levels that are approximately 33% of normal at birth. So they do a screening test for the hypothyroidism as the patient may be asymptomatic at birth. These low serum level of T4 and concomitantly elevated level of TSH make it possible to screen and detect hypothyroid neonates. The clinician is dependent on neonatal screening tests for the diagnosis of congenital hypothyroidism. Although laboratory errors may occur and awareness of early symptoms and signs must be maintained, so we must depend on both clinical awareness and in addition to the screening program. These clinical features, I put it in red lines, which are the important clinical features we must look for. First, birth weight and length are normal at birth, but head size may be slightly increased because of myxedema of the brain. So the height and the length and the weight may be normal at birth. Prolongation of physiological jaundice, one of the most common presenting features, may present to us with prolonged neonatal jaundice and refer to the endocrine department because of prolongation of the physiological jaundice, and when do thyroid function tests proved to be hypothyroid. Feeding difficulties, especially sluggishness, lack of interest, and choking spells during feeding are often present during the first month of life. Respiratory difficulties, which may be due part to the large tongue, which include apneic episodes, noisy respiration, and nasal obstructions. Affected infants cry little, sleep much, and have poor appetite and are generally sluggish. So it is cry little and sleep much. And sometimes the mother feels that this is maybe normal, but this should aware us, and we must take it in consideration when there is a cry, when the patient or the neonate cry little or sleep too much. Put in mind that congenital hypothyroidism may be the cause. There may be constipation or delayed passage of meconium that does not respond to treatment. and the abdomen is large with umbilical hernia is usually present. So, when there is distended abdomen with umbilical hernia in a neonate, we must keep in mind this could be a sign of congenital hypothyroidism, but not essential in every case. The temperature is subnormal, often less than 35 degrees centigrade, and the skin, particularly that of the extremities, may be cold and mottled. Edema of the genitals and extremities may be present. Pulse rate is slow. In addition, there may be heart murmur, cardiomegaly, and asymptomatic pericardial effusion. Macrocytic anemia, that means increased MCV, is often present and is refractory to the treatment with hematinics unless we are treating hypothyroidism by thyroxine. Because symptoms appear gradually, the clinical diagnosis is often delayed, and approximately 10% of infants with congenital hypothyroidism had associated congenital anomalies. Cardiac anomalies are most common, but anomalies of the nervous system and the eyes have also been reported. In addition to that, if the congenital hypothyroidism goes undetected and untreated, these manifestations progress and retardation of physical and mental development becomes greater during the following months, and by 3 to 6 months of age, the clinical picture is fully developed and the patient will have mental retardation. The child growth will be stunted, the extremities are short, and the head size is normal or even increased. Thus, to say disproportional growth retardation. The patient presents with short stature with short extremities. The anterior and the posterior fontanelle are often widely opened, and observation of these signs may give initial clue to the early recognition. So, one of the cause of the persistent anterior fontanelle or large anterior fontanelle is the congenital hypothyroidism. The patient has coarse features, facial features. The eyes appears far apart, and the bridge of the broad nose is depressed, and the palpebral fissures are narrow, and the eyelid swollen. The mouth is kept open and thick broad tongue protruded. Dentation will be delayed. The neck is short and thick, and there may be deposit of the fat above the clavicle and between the neck, that's to say buffalo hump. The skin is dry and scaly, and there is little perspiration. Myxedema is manifested particularly in the skin of the eyelid, back of the hand, and the external genitals. Carotenemia may cause yellow discoloration, but what differentiated from jaundice is that the sclera remain white, while in jaundice the sclera become yellow. The hairline reaches far down on the forehead, which usually appears wrinkled, especially when the infant cries. Development is usually retarded, and hypothyroid infants appear lethargic and are late in learning sit and to stand. The voice is hoarse, and they do not learn to talk. The degree of the physical and mental retardation increases with age. Sexual maturation may also be delayed. These are the pictures of neonate with hypothyroidism. As you see, there is a coarse facial features, narrow palpebral fissures with edema of the swelling of the eyelids, depressed nasal bridge, protruded tongue, large tongue, and low hairlines. In addition to that, we see the distended abdomen with umbilical hernia. So the patient, these features may give a clue to or initial clue to the diagnosis of congenital hypothyroidism. Regarding the laboratory findings, most newborn screening program measures level of T4, followed by measurement of the TSH when the T4 is low. This is used in USA, while in European and Japanese neonatal screening program, they are based on a primary measurement of the TSH. If the TSH is high, then they do confirmatory test. Regardless of the approach used for screening, some infants escape detection because of technical or human errors. So, clinicians must be careful about the clinical manifestation of hypothyroidism, as some cases may be missed. Serum levels of T4 and T4 or free T4 are low, usually are low, and the T3 may be normal. and are not helpful in the diagnosis. The defect is primarily if the defect is primarily in thyroid, the level of the TSH are elevated, often to the greater than 100 microunit per liter. We have some cases which is called secondary hypothyroidism, when the defect is in the pituitary, in which there will be T4 low in addition to the TSH low. So keep in mind there is different presentation of primary or different laboratory finding in primary and secondary hypothyroidism. Serum levels of prolactin are elevated, correlating with those of the TSH. Retardation of the osseous development can be shown radiographically at birth by X-ray in about 60% of hypothyroid infant, and indicates some deprivation of thyroid hormone during intrauterine life. We do X-ray of the knee. The distal femoral epiphysis, which is normally should be present at birth, will be absent in patient with hypothyroid, but it is only in 60% of the cases. In undetected and untreated patient, the discrepancy between chronological age and the bone age increases, so the patient may present with short stature and delayed bone age. Ultrasound examination of the neck or of the thyroid is helpful, but studies shows that it may miss some ectopic gland, especially when it is present in the lingual thyroid or in other side of the neck. And thyroid scan can be helpful to pinpoint the underlying cause in infant with congenital hypothyroidism, but treatment should not be delayed for this study, as it is not always available during diagnosis of congenital hypothyroidism at that time. The scan used either iodine scan, radioactive iodine, or technetium scan. ECG may be show low voltage B and T wave with diminished amplitude of the QRS complex and suggests poor left ventricular function and pericardial effusion, but it is not essential to do it in every case of or for the diagnosis of congenital hypothyroidism, only when there is possibility of cardiac lesion. In children older than 2 years, the serum cholesterol level is usually elevated. We don't need to do all these tests in every patient with congenital hypothyroidism. We may depend on low T4, high TSH, and sometimes ultrasound, and in some cases we do thyroid scan. Regarding the treatment, levothyroxine, that's the thyroxine, it is given orally in the form of tab, which is the treatment of choice, and it is given orally before breakfast on empty stomach. In a neonate, the initial starting dose is about 10 to 15 microgram per kg per day, which is high dose when we compare it with the dose of children or adult. In children, we need only 4 microgram per kg per 24 hours, while in adult it requires only 2 microgram per kg per day. This is essential because this is important, as it is the thyroxine is essential for the development of the brain, and without it, a patient may present with mental retardation. Regarding the follow-up, levels of the T4 or free T4 with TSH should be monitored at recommended intervals, thus to say, monthly for the first 6 months, and then every 2 to 3 months between 6 months and 2 years, and then every 6 months during the period of follow-up. Regarding the prognosis, early diagnosis and adequate treatment from the first week of life result in normal linear growth and intelligence comparable with that of unaffected siblings. Thus to say, if we pick the patient early and treat early with a proper follow-up, then the prognosis will be excellent. Approximately 20% of children have a neurosensory hearing deficit, so hearing assessment is essential for every case with congenital hypothyroidism during the period of follow-up. Without treatment, affected infants are profoundly mentally deficient and growth retarded, and so congenital hypothyroidism regarded as one of the preventable causes of mental retardation. Thank you very much.